that introduction, and I apologise if anyone finds any of my slides a little offensive, but I think you should be okay. So I'm going to talk about the drug management of type 2 diabetes, but that sort of also brings in the management of overweight and obesity, because the two conditions, as you've just heard from Dr. Tonks, are very closely related. So I'm not going to labour this point, which is my only introductory slide, but Dr. Tonks has already told you again that there's at least 1 million people, or there were at least in 2014, with diabetes in Australia, and half of those individuals don't know they've got it because it's asymptomatic. And that's the really scary statistic, because those are the individuals that often come into hospital with a heart attack or a stroke or kidney failure who are diagnosed with diabetes, and you actually do worse in terms of outcome if you have undiagnosed diabetes versus diagnosed. So I echo Dr. Tonks's remarks about screening, and I think it's very important that that is done actively and proactively. It's ranked in the top 10 leading causes of death, and it's the underlying cause of death in 3% of all deaths that are reported. And it's interesting that if you look at the type 2 diabetes distribution within New South Wales, the red is the highest distribution and the dark blue is the lowest, and you can see that most of type 2 diabetes, or most individuals with type 2, or the majority are living inland rather than on the coastal. And if you look at type 1, it's a very, very different picture. Now that could be because that's where the care is centred. Younger people might be more likely to live in the city than not, but I think they're interesting statistics nonetheless. This is confronting slide number 1, I think. But this sort of graphically just highlights some of the complications of diabetes. And this is the reason, I suppose, that I get up every morning, is really to try and prevent these complications developing in the patients that we treat. And Dr. Tonks has already showed you this slide, but just to make the point that some of the major abnormalities, again, are insulin resistance that you've heard about, but also a reduction in the amount of insulin that you secrete. And as you've been told, these abnormalities occur even before diabetes is diagnosed. So it's really important to screen and pick up these abnormalities. And all of the drugs that we're going to talk about today for management of type 2 diabetes have been designed to improve insulin resistance, so make insulin work better in the body, or to improve how much insulin the body actually makes. And it's a very tight relationship between those two that's involved in controlling blood glucose levels. So how do we manage type 2 diabetes? Well, one of the things that we need to think about is managing people's weight. So physical activity and calorie restriction, you'll hear a lot about in the second half of this seminar. Psychosocial factors are often forgotten about. These are really important things that we need to think about, and I'll show you one study about social factors next. Weight loss drugs are really important medications. We don't have very many on the market. There have been a few that have been introduced in the last few years, but they've been withdrawn, unfortunately, because of potential adverse effects. Sleep hygiene is very important, so getting a good night's sleep, and the recommendations are at least 7 to 8 hours per night. And there are nice studies to show that people who sleep less have a higher risk of metabolic diseases, including diabetes and heart disease. And finally, of course, bariatric surgeries, the surgical procedures to induce massive weight loss, are recommended for people who are very overweight or obese and have diabetes complications and diabetes itself. But the problem is the access to some of those procedures, because they're rarely funded by the government, makes them of limited benefit. So this is the only study I want to show you about social factors, and this was an interesting study that you should all read, that was published in Obesity Research now a little while ago. And what it suggests, well, as you can see, it's an American study, so they talk about becoming married and then becoming unmarried. But in men who get married, their body mass index, and in women, goes up almost 1 kilogram per metre squared. So you put on a few kilograms when you get married. When you become unmarried, as they say, men really don't lose any of that weight. But women often do lose a similar amount of weight, or BMI, that they gained when they got married. So as you can see, in men, I suppose, if they have a number of marriages, their weight will probably continue to go up. Whereas in women, their weight will probably stay fairly stable. And this is not my opinion, but this is what the authors say, is that their possible explanations are that marriage increases opportunities for eating, probably true maybe, and people who leave a marriage lose weight to increase attractiveness, and those who get married gain weight because of a weakened motivation for keeping weight down. These aren't my views, by the way. My wife would kill me if she saw me present this. But I've asked a couple of other people, done a survey about why married women are more obese than single women, and I've been told that single women come home, see what's in the fridge and go to bed. Whereas married women come home, see what's in bed and go to the fridge. Anyway, back to the topic. So, the other drugs for type 2 diabetes, these are the list of medications that we use. And as you can see, what we used to have available to us was just the top two plus insulin. But now we have a whole other list of medications that we often need to think about. And there's going to be a test at the end of this session about these drugs. These are the choices that we have when we see individuals who are coming to our clinics for treatment of type 2 diabetes. And as I said to you, about 10 years ago, there were the top two drugs plus insulin. And now you can see there are multiple classes of agents that are available for diabetes treatment. These are the sort of decisions that the societies, decision trees the societies put out when we have to make a decision about what drug. So as you can see, there's no right answer. At the top of the list are lifestyle measures, diet, exercise, weight control. Then first line is metformin, which we'll talk about briefly. That's the usual first line treatment, unless there's a problem using it. That's Diabex, diformin, etc. But as you can see, when we get down to the second drug, there are many choices. And these are the classes of agents that we can use, third-line drugs, and then others. And many patients, or most patients with diabetes, are on a combination of medications to attack the diabetes pathophysiology from a number of different angles. So metformin is still first-line for diabetes. The majority of people with type 2 diabetes should be on metformin unless there are kidney problems or unless they don't tolerate metformin, because it's a really useful drug. It's an insulin sensitizer, so it improves how well insulin works in the body. There is really no risk of a low blood sugar level when it's used alone. If it's combined with other medications, they can sometimes cause low blood sugars. This is a little controversial and doesn't occur in all patients, but a lot of patients who go onto metformin might lose a little bit of weight. It's difficult to tell whether that's the drug or the lifestyle changes that people make when they're diagnosed with diabetes, but it doesn't cause weight gain, I think we can fairly say. There are some good data to show that it also is able to prevent or reduce the risk of diabetes development in people who are predisposed. As I told you, it's not used in people who've got bad livers or who've got kidney problems because of this potential condition called lactic acidosis, where the acid level rises too high in the blood, but that's an exceedingly rare condition. And there is a risk of B12 deficiency, so people who are on metformin should, from time to time, particularly if they've got nerve damage in the feet, have a vitamin B12 level measured, because metformin causes the body not to absorb vitamin B12 as well, and that should be replaced if it's low, because it might help general well-being, energy levels, and particularly symptoms related to peripheral nerve damage. Now, there's another newer class of agents called the GLP-1 drugs. And what happens when we have a meal is it stimulates these cells in blue here in the gut, and they secrete this active hormone called GLP-1, glucagon-like peptide 1. Don't worry about the name. But it's a key hormone that's secreted from the intestine that causes insulin to be secreted from the pancreas. And therefore, the drug companies thought, well, this is a good target. We can stimulate this receptor here, and that might increase how much insulin the body makes. And they developed these drugs called the GLP-1 receptor agonists, and I'll go through those briefly. But they also developed drugs, which are tablets, which block the breakdown of this hormone. So these are how the drug companies have developed some of these newer medications. Now, this is the Gila monster, which lives in the Arizona desert. And the reason why I show you this picture is because the venom contains a substance that mimics this GLP-1 hormone. And therefore, the companies have copied this agent, and they've developed drugs that are actually mimickers of this GLP-1 drug. This particular drug, exenatide, is injected twice a day before meals. You can use it and get reimbursement for it if it's used with other tablets, but also if it's used with long-acting insulin. The main adverse effect or side effect of this drug is nausea. Some patients develop it and they have to stop the drug, others never develop it at all. But for this reason, we start off with a lower dose of the medication and increase it over a period of time. There's a question mark about inflammation of the pancreas or pancreatitis. It probably doesn't cause this, but anyone who's had pancreatitis or inflammation of the pancreas in the past, we wouldn't use these drugs. And the main benefit is that it causes about a 5 kilogram weight loss compared to insulin at 1 year. So insulin causes people to gain weight, whereas these drugs, the ones that stimulate GLP-1, often, in most patients at least, cause some degree of weight loss. So they're very beneficial agents for using in type 2 diabetes. The other drugs in this class are called liraglutide, and this is given as a once-daily injection. And then there's a long-acting exenatide. This is by Giardia. It's given once a week instead of twice a day. And this is a once-weekly injection that can be given to people for type 2 diabetes treatment, again, that induces weight loss. And it's quite a useful medication, as I said, because it only needs to be given once a week. And these are all injections that patients give themselves. And this is just a research study published in the New England Journal of Medicine that showed that the use of one of these drugs actually lowers the risk of developing heart disease in patients with type 2 diabetes, or at least adverse heart events. So they've got other benefits apart from just blood sugar and weight. Now, Dr. Tonks talked about diabetes and pissing evil, and that's a bad thing, but there's a newer class of agents that, interestingly and maybe paradoxically, have been developed that make pissing evil the thing to do. So these are the SGLT2 inhibitors. These are the 3 drugs, dapagliflozin, if you can, this is a new language I think for most people, canagliflozin, also empagliflozin. And these drugs are Forxiga or Xigduo and Jardiance or Giardia Met, which many people who have type 2 diabetes would be treated with. And what they do is they actually stop you taking up sugar in the kidneys. So normally what happens is the body is very efficient in conserving energy, and it'll draw back all of the glucose that's filtered through the kidneys back into the body. And what these drugs do is they actually increase the amount of sugar that is excreted in the urine. So you're pouring out more glucose. Therefore, they drag water, and therefore you also break down some fat, and you get weight loss from these drugs. But because you're having more glucose in the urine, bugs like glucose, and therefore there's a slightly higher risk of urinary tract infections and also thrush. So we would avoid these agents in individuals who have a propensity to developing recurrent urinary tract infections or thrush, and their side effects to make people aware of, because if they develop, we might reconsider using them or not. And this is just to show you pictorially what happens is that glucose normally goes through the kidney, and it's normally reabsorbed in these cells here by this transporter SGLT2. And what happens is that we block this with the drug, and therefore more glucose is filtered out into the urine. These drugs induce weight loss. So this is from a research study published in this journal in 2012, and it shows you the change in body weight. And these are just different doses of the medication at 24 weeks. And with the highest dose, what you can see here is there is at least a 3 kilogram weight loss with these drugs. Again, making them very attractive drugs to use in people with type 2 diabetes, particularly if they're overweight. And there was a lot of hype around one of these drugs called empagliflozin or Jardiance or Giardia Met about 1.5 years ago now, because as you can see here, this drug is associated with a lower risk of dying from a heart attack in people who have diabetes and known heart disease. So we preferentially use these drugs in people with diabetes and heart disease because of the benefits in terms of mortality. And this has really been a major advance in our understanding of how these drugs work and their benefits. And now the FDA in the US mandates that drugs are shown to have no negative effect on heart disease, but unexpectedly what's coming up is that a lot of these drugs actually have benefits in terms of reducing heart disease. So anyone with heart disease and diabetes, this is probably one of the drugs to be on. And it also slows the risk of kidney disease. So in the last couple of minutes, I'll just mention insulin therapy to you. It used to be said that after about 10 years of having type 2 diabetes, most individuals required insulin therapy because the beta cell in the pancreas that makes insulin becomes exhausted and is unable to keep up with the demands of the body and insulin resistance. And that dogma's changed a little bit now because we have so many other agents that we can use to treat type 2 diabetes. But insulin is still used in a large number of people with type 2 diabetes when all of the other drugs have failed or no longer work, or the insulin is unable to be secreted in large enough amounts to maintain normal sugars. And this should not be viewed as a time of failure, but it's almost something that occurs in a large number of people because of the pancreas just giving out. And a large number of our patients, although they are reluctant initially to use insulin, are actually relieved because they're able to cut down on a number of other diabetes medications, their blood sugar levels improve significantly, and they often feel better on insulin therapy, which can sometimes just be given once at night before bed. Insulin is given in pens, but it can also be given in an insulin pump. And I'll just show you a couple of slides about insulin pumps, because these are now pumps that can be used not only in type 1 diabetes, where they're traditionally used, but also in type 2 diabetes. It's not reimbursed by the government, but there are a few patients who are starting to go on insulin pumps with type 2 diabetes with significant benefit. The average cost of one of these pumps is about $10,000, so it's not something to be sneezed at, and it's not something you want to leave on a plane when you get off, but they're useful devices in some individuals who would like to be on them, particularly some of the younger children when they develop type 2 diabetes. There are many different types of insulin. You've got the short-acting insulins here, the slightly longer-acting insulins, and then the really long-acting insulins that can last up to 24 hours. So there are many different choices. They can be used in combination, so there are combination insulins with short and long-acting. There is once-a-day long-acting insulins. Some individuals with type 2 can go into 4 times a day, or there's also insulin pump therapy, as I mentioned. So what is an insulin pump? Well, it's this little device that's smaller in size than a mobile phone that injects insulin continuously through this little port where a little needle goes under the skin, and it constantly infuses small amounts of insulin into the body. It's a small electronic device, as I said, that gives continuous insulin. It's worn for 24 hours per day. It's an alternative to insulin injections, but it's not as if this infuses insulin and you then don't have to test your sugars or think about diabetes. You still need to program the pump, and a lot of information and time needs to go into managing diabetes with a pump. And as I said to you, this is not first-line therapy. There's only a few people with type 2 diabetes on insulin pumps, but over time they might become more and more user-friendly and used in type 2 diabetes. Now, these are what the pumps used to look like, similar to a small computer, as you can see, connected up here to the arm. And as many of you will probably remember, when I was a child growing up, the computers used to fill whole rooms. And similarly, insulin pumps used to be very, very big devices. And it's not the sort of thing you could obviously take when you go out and for a social occasion or for a swim. But now these are what the insulin pumps look like. These are the pumps. This is how it's infused. And we now have sensors that can be used which attach to the other side of the tummy here, which pick up glucose levels, and they can talk to the pump, and the pump cuts out infusing insulin when the glucose level is too low. So as you can imagine, particularly for people with type 1 diabetes, these are very useful devices, particularly in children, where you want to make sure that you avoid a low blood sugar level that goes unnoticed. So as I said, in type 1 diabetes, insulin pumps are used commonly, sometimes used in pregnancy, but in type 2 diabetes not used terribly often, but they're important to be aware of. And there's some sort of famous people that are using pumps. There are athletic pumpers. This is Gary Hall Jr., who was a US swimmer who won gold, silver and bronze at the 2000 Olympics. There'll be a prize for whoever can find where his pump is. It's not meant to be a rude question. But the answer is there's no pump. He's not wearing it because he's about to jump in the water. And if he had a pump on in the water, at least the brand that he was using, it wouldn't work terribly well. So he can take his pump off, do his race, and then pop it back on. There are other pumpers here. Again, the question is where Sirius Anderson's pump is. It's Miss Idaho, as many of you will be aware, at least I was, in 2014. And if you look here closely, you can see that she's wearing a pump when she came out on stage. So these are proud pumpers, and there are many individuals who wear these pumps and participate in normal lifestyles. So I'd like to end on that point and just hopefully make the point that there's been an exponential increase in the number of diabetes treatments that have become available in the last 10 years or so. So it's a really exciting time to be able to talk to you about these therapies. Some of the newer drugs, such as the GLP-1 drugs, the lizard venom drug, the SGLT2 inhibitors, the pissing evil medications, provide choice with some benefit in terms of cardiovascular disease. And finally, we now have some of these once-weekly therapies that might be preferable to the daily or second daily or third daily medications that we have on the market. So thank you for your attention, and we'll look forward to